The most critical bit, if we're treating and managing disease, is to get the patient back and review the work you've done on them, review their behavior change. And term again, which I think should be thrown out, is monitoring. We use this term all the time. That's a passive throwaway term. It means nothing. A much better term is active surveillance. Now, if you have a situation where you've got a buccal cervical lesion, the reason why this is so important, because we're talking about should we go in with a drill and everything else, you might still have cavitation. Well, you will still potentially have cavitation. So does that mean you pick up a drill and drill a hole? Absolutely not.
What is the one thing that you think could level up our caries diagnosis in addition to good clinical observation and radiographs?
There is plenty of evidence to show in the right patients, right situations, it can work very, very effectively. So it's a big thumbs up. And you were commenting it's fiddly. Everything in dentistry is fiddly until you become practiced at it, isn't it? You know? And the fact of the matter is, the first time you put rubber dam on, it was fiddly.
Yeah, oh yeah.
The first time you handled a bonding agent, it was fiddly, and so on and so forth. The more you do things, the less fiddly it becomes.
This is a huge one, Protrusive. Over the next 2 episodes, I've got you a world-renowned professor of cariology, Professor Avijit Banerjee. He literally writes the books about caries. What prof doesn't know about caries is not worth knowing, and it's something that we fight every day. As general dentists, we diagnose and manage caries deep in the trenches of our patients' mouths. It is Dentistry 101. It is the most prevalent disease in the world. But yet there is still so much confusion on its diagnosis and management, and this 2-part series is going to give you frameworks and clarity, and I'm so excited to put these 2 episodes on for you guys. In this part 1, we find out if there's anything new, anything contemporary, anything worthwhile in caries diagnosis. This is important because our diagnosis will dictate our management. To drill or not to drill is always the question. And the funny thing about that is if you show a different dentist the same radiograph, you're going to get different answers as to whether they take a drill to that tooth or not. Should we be more unified in our consensus and our diagnosis? And to which level of diagnosis should we be undeniably picking up the burr versus actually reaching out for something else? And I'm going to already give you the protrusive dental pearl inspired by this episode. I've implemented this already. And so the pearl is we're no longer going to use the term monitoring. We don't monitor our patients for caries. We don't watch, we don't monitor. Delete those terms now. From now on, we will be implementing active surveillance, okay? And you'll see why this little small shift in terminology is so powerful. As a patient, when you hear monitor versus active surveillance, it means 2 different things. And the term better reflects what we actually do. We take radiographs, we check extra carefully clinically, we triangulate all the data, and you'll hear more about that in this episode. We also find out if the caries detection in the intraoral scanners is any good. Does Professor Banerjee like the AI diagnosis of caries? Is it a boon or a bane? And another huge takeaway from me, which you must listen to, is his thoughts as a professor on proximal resin infiltration. Again, is it a fad? Or does it scientifically actually work, and does it hold up? I actually know very few clinics at the moment that offer proximal resin infiltration. Is this slow uptake justified? Or should we be offering resin proximal infiltration to every patient with early caries? And then we start touching on peptides, something I didn't actually know much about, but we'll save that for part 2. This episode will give you so much more clarity on the frameworks and protocols, starting with the diagnosis of caries and how we've progressed and advanced in caries detection. Please share this episode far and wide, my dear friends. This is a truly universal episode, and I'm convinced it's going to hit the Protrusive Hall of Fame. When you feel those light bulbs going off and you're enjoying it, do not forget to hit that subscribe button, and I'll catch you in the outro.
Professor Avijit Banerjee, it is such a huge pleasure to have you on the podcast. It's been a long time coming, to be honest with you, and honestly, I don't know how much of this you would have seen, but behind the scenes, how much excitement there is in the protrusive community. When I announced, I didn't drop your name, but I said there's a professor of cariology coming on the show. And then even just from that, right, everyone's like, whoa, I'm really looking forward to this. And then when I dropped your name, they're like, okay, this is going to be epic. So we're really looking forward to it. What you've contributed in the field of cariology and dentistry and education is immense. For those people listening who may not have heard of you, very few people, please tell us about you, about yourself, about your current positions that you hold and your passion.
Thanks, Jazz, and it's an absolute pleasure to be here, and I really do appreciate being invited. I think what you do with the community you have, I think is really immense, and it's a privilege, as I said, to be part of it, a small part of it. So yeah, I'm working at King's College London at the Faculty of Dentistry, Oral and Craniofacial Sciences. Used to be Guy's, but now it's King's College. I've been there pretty much all my professional life. I trained there and still working there now as a chair, and probably will retire there, who knows. So as you rightly say, my area of interest in clinical and academic has always been sort of cariology and operative dentistry. And so after climbing through lots of different sort of DCT and house jobs and doing a master's and a PhD and specialist training, I'm currently a professor of cariology and operative dentistry there. I have multiple other hats. I'm an honorary consultant in restorative dentistry as well as part of Guy's and St. Thomas's hospitals. I am an honorary clinical advisor to Jason Wong, who is the current Chief Dental Officer for England. I'm getting involved more and more with national policy, which I'm sure will come out in this discussion during this session. I am currently Dean of the Faculty of Dentistry for the College of General Dentistry, the new college that's there, CG Dent, which is a new college there for primary care practitioners and the oral health care team. So real privilege and an honour to be the first dean of that faculty. The South London Research Delivery Network Specialist Lead for Oral and Dental, which is part of the NIHR. Again, it builds in all this sort of research that goes on in the UK. And linked to that, I'm also currently president of the British Society of Oral and Dental Research, BSODR, where we're really actively looking for more team members and practitioners to get involved with research, especially in primary care. And I suppose last but not least, I am now editor-in-chief of the British Dental Journal portfolio, which is the sort of strategic editor of all 6 journals within that portfolio. So yeah, pretty busy, 8-day week, but good fun, but really good fun.
I can just vouch for the fact that, yeah, one thing you didn't touch on too much, but how many publications you have and how you are involved in research. Obviously, we can go on and on. Prof, do you remember the first time we met?
We've worked together, certainly. We published together, that's for sure. And I'm just trying to think back how many years ago that was now. That's probably frightening. I don't really want to know.
That was over 10 years, maybe 12 years ago.
12, 13, yeah, exactly. Absolutely.
But the way you probably don't remember because you're the professor, right? You don't remember, but as a student, you remember every scolding, every something, right? So it wasn't quite a scolding, but let me tell you what it was, right? I knocked very timidly. I knocked on your office, right? Because oh my god, I was about to meet the Prof. Energy. I had a proposition for you, right? Had something I wanted from you. Okay, I wanted to work with you, right? And so I knocked on your office. You kindly allowed me in, sat me down, and you asked me about my interests and what you want to do. And I said, look, I want to publish something in Dental Update. And then you put me on a task. You said, look, Jazz, do this thing for me. It'll probably take you 15-20 minutes. Okay, I want you to just look at what's been published in Dental Update in the last 10 years, and then bring it back to me, okay? Fast forward 4 hours in front of a laptop. I can tell you now, almost cursing your names, like, how did he think, I don't know, was it, you knew this or you didn't know this, but this is no small 15-minute task. It took me 4 hours to do this. Anyway, I presented it to you, you were really impressed, and then that's how we agreed to do the RBB paper. And then, but so nice for you to pass that on to Trevor Burke. And then he sent me a handwritten letter saying, that was really good data, thank you so much. Absolutely. So I just wanted to tell you how intimidated I was the first time I met you, but it was an honor and privilege to work with you. And now I get to talk about caries with you. And look, just tell you a bit about the audience. We have all ages, and we have students all the way to retired dentists who just listen because they like to hear about dentistry, right? So we have a whole spectrum, and I think everyone has something to learn today. So I have so many questions, and we've got the time set out for this. And so I will start with the following. Just some definitions before, yes, we could talk about policy, which you touched on, but I really want to get into the small details and how they might have changed over the years, right? Yep. So firstly, let's start with a bigger picture. Minimal, so I get the letters right, MIOC and that's MID. It. Okay, what do they stand for, and what do they mean to you when you, for example, when you write them? There's a way that a dentist may interpret it, but I want to hear from you. How was it intended? What was the message behind that? The intention.
Great, thank you. Really, really important question, because it's actually we're shifting the dial in the way we manage caries and we look after patients, right? And let's cut to the chase here. We've been doing too much traditional work for too long, which has been primarily, you see disease in the mouth with your eyes, with loupes, with whatever detection technology, we see cavities and we salivate and we want to drill them and fill them, okay? And our systems then pay for that. So that's been going on for decades and decades and decades. And I'm not saying that's wrong, but that isn't actually looking after patients and treating disease. That is actually just literally filling holes and treating the consequence of disease. Okay, so it's really treating the symptoms, nothing else. So there have been terminologies and principles and philosophies that have been around for a long, long, long time, but because people aren't sure what they mean, exactly the sort of direction of the question you're asking, the words get all muddled up and used interchangeably, and therefore they lose effect. And in the last decade or so, when I've been doing more policy work, it became really clear to me when you're trying to explain to different stakeholders, funders, policymakers, government, NHS, whoever, people aren't sure what we do in dentistry. It's quite frightening. It's really quite frightening. So I looked at what's been done out there, and it's basically reinventing the wheel, but to clarify things a little bit. And therefore your question is very pertinent. So you've heard of minimum intervention. You've heard of minimally invasive. These are terms that are around there. They're bandied around by pretty much everybody. And it's MID, minimum intervention dentistry, or minimally invasive dentistry. And many people, practically all the profession, all stakeholders, use these terms interchangeably, but they're not the same. So minimum intervention oral care. So get rid of the dentistry because it's more about the mouth than just teeth. So it's minimum intervention oral care, or MIOC, MIOC. This is a delivery framework, and it's common sense. It's going to be prevention-based. It's going to be person-focused, so individualized. It's going to be susceptibility-related, and it's oral healthcare team delivered, not dental team, oral healthcare team. So those are the four underpinning principles. And minimum intervention oral care, within those four principles, has four very simple interlinked clinical domains. So clearly the clinician needs to identify the problem that the patient is suffering from. So you've got to do your examination, your history taking, your detection, your diagnosis, your special investigations, all those things. You've got to do your risk susceptibility assessments, and you've got to pull all that together to develop not a treatment plan. Again, these are antiquated terms that need to be thrown out. Our medical colleagues don't use any of this terminology and haven't for 25 years, but we still continue to do so. It's a personalized care plan, not a treatment plan. And I'll come back and explain the difference a little bit later. So you develop your personalized care plan and you stage this care plan. It happens sort of in phases. So you do that. So that's the first domain. And that can be done by all members of the oral healthcare team, not just the dentist. So dental hygienists, dental therapists, extended duties dental nurses, reception staff, practice managers, everybody gets involved in that in a different way. The second domain is then prevention of lesions and control of disease. And again, terminology is everything. You said you wanted to get right into the nitty gritty, and I'm pleased you did. It's prevention of lesions, control of disease. The disease, caries, occurs in the biofilm, occurs in plaque. Okay? You don't prevent that. You don't prevent plaque. Therefore, you don't prevent the disease. You control it. It's a balance. That's what you were taught at dental school, the seesaw, right? But what you can do is prevent the consequence of disease, which are the lesions, which is the white spot lesion right the way through to a dead pulp. Okay? So you prevent lesions, control disease. And that's all about behavior management of the patient and also of the profession in terms of learning to do the right thing. And we do primary prevention that occurs at home, i.e. the patient does the work with a toothbrush, with floss, with toothpaste, with controlling the diet, all those sorts of things. And then we might also include secondary prevention measures. So when early disease starts, we can reverse it. And that we use microinvasive technologies and protocols. So what I mean by that are sealants, preventive sealants, therapeutic sealants, and sealant restorations. It could be resin infiltration technology. It could even be peptide infiltration mineralization technology as well. So these
can you tell me that's the only one I don't know anything about, which we'll touch on later.
Absolutely. I'll come back to that. So these are microinvasive interventions that the team can deliver to the patient in the clinic. And what I mean by microinvasive is you are going at a micron level into the porosities of the tooth. Yeah.
Does fluoride varnish and silver diamine fluoride encompass within this?
They're linked in that. Absolutely. Okay. Absolutely right. Then the third domain of minimum intervention oral care is minimally invasive operative dentistry. So patients that we see who've got holes in their teeth, they need treatment, they need fillings, they need excavation, they need, whatever operative intervention is correct. But that has to be done minimally invasively. So that's where MID comes in, minimally invasive dentistry. The fourth domain, the final domain, is reassessment and recall. So we often see our patients do the fillings and the patient walks away and we don't see them again for 6 months, 12 months, or even longer. Well, actually, the most critical bit, if we're treating and managing disease, is to get the patient back and review the work you've done on them, review their behavior change and that they're adhering to the advice that we are giving them. And term again, which I think should be thrown out, is monitoring. We use this term all the time. That's a passive throwaway term. It means nothing. A much better term is active surveillance. And if you think about it, when I was first told about this terminology at a US pediatrics Caries summit, my US colleagues told me about this, and I immediately was thinking of FBI agents, black suit, white shirt, black tie, shades, the earpieces, sort of tapping into your phone, reading your emails and things like this. Metaphorically, that's what we should be doing with our patients. We should be getting involved. We should be actually assessing and checking, not just passively looking in the mouth going, yeah, everything's fine, and move on. And these...
Can I just add there, like some people may be listening and thinking, but Prof, this is just semantics. But I think semantics are important because they kind of go on to define how you approach something. And the reason I like this shift from monitor to active surveillance is I literally sent an email to a patient yesterday where I looked at her radiographs when I used to work in a previous practice and most recently. And I said to her, okay, don't worry, we don't need any active intervention. You don't need to book anything in. But I said to her, I'm watching this one like a hawk, right?
Bingo.
And so that kind of summarizes rather than we're going to monitor. It's just much nicer for the patient to read. Like monitor versus I'm the patient, I'm reading something. And in my treatment plan or management or care plan, it says, let's say it says monitor versus active surveillance. It just feels like better that I'm in safe hands here.
Absolutely. And again, you've nailed it on the head. So not only is it actually a better descriptor of what we're doing, because it is, as you've just highlighted. But you've also got to think, if we want to change policy, people like myself and others have to go to government, have to go to people who don't understand what we do. And you've just nailed it. They're a patient. We're just monitoring you. It means nothing. It means nothing to anybody, because how do you define that? Whereas active surveillance will be double checking and periodically checking their susceptibility to disease. We'll be obviously checking for new lesions or progressive lesions or reversal of lesions. Doesn't always involve, it can be done through teledentistry. And that's, we had many negatives of COVID a few years ago, but one of the positives, I think, is the fact we can do this sort of thing now, which people didn't do really very much 6-7 years ago. But we can also do this with our patients. And we've got to think outside the box in how we deliver this care and this active surveillance and this supportive care. So those are the 4 domains. So identifying the problem, prevention and control, minimally invasive operative, and then the recall, reassessment, active surveillance. And that is what makes up minimum intervention oral care.
I think, and I speak for our listeners and watchers, that really, when they break it down, sometimes when it's presented this way, it can be like, but do we really need to add all these words and stuff? But what this does, it kind of puts a frame around it, and it helps
Absolutely.
to remind us that it's not just drill, fill, and bill. It
Correct.
really sets that framework that we have, and I think most of the community, all the dentists listen to this, who tune into this podcast in particular, reassuringly already doing this.
Absolutely.
It's just a nice reminder, because yes, we need the patient to play their part. Then we need to do the sort of at the micron level, like you said, work on the prevention that we can. Active surveillance is a great shift, the operative care that's required, but then the active surveillance comes afterwards. And I think all it's done is it's a good reminder, reassurance, because really this is what we were taught at dental school. It's just a good reminder, and it's a nice clear pathway that again moves it away from the drill, fill, bill, and treat and plan.
Exactly. And again, you've summarized that perfectly. It is exactly that. It's as I said at the beginning, this is nothing new. It is just putting it into boxes, if you like, or under headings, which allows us then to use our teams more effectively and actually not only provide the best care, which clearly this would do. And I completely agree with you. Anybody who's listening to this is probably already doing this because they're interested.
I think if there's a change, I was just just based on this, how many of the minutes we've been recording so far, and I'm always like, when I learn something or something that gets validated, unless you act on it and look at your protocols, it's wasted knowledge. And so what you've inspired me to do now is when I do my Loom video plans to patients, or when I do my letters to patients, just to summarize, okay, what's the care plan for them? I'm just going to, instead of saying, hey, you need to come in for restorations this quadrant, I'm going to, hey, you need to make sure that you do all these 5 things I told you at the clinic for prevention. We're going to look for any sealants, and just to break that down, not to make it longer, but to make the patient understand a bit more about what's going on in the mouth, that they do have power to prevent this. And it's not just, hey, you got to come in for this intervention. So it's kind of breaking it down in a way that really the patient can better understand, and it actually puts that philosophy that you said into practice, even in your communication.
Again, absolutely spot on. And this is the whole point of doing it, because what, in a dentist's head, as I said, they're probably doing a lot of these things, but they're not doing them perhaps in a nice structured order. They're not necessarily writing things down. They're not necessarily communicating them. And I repeat again, with the changes in NHS policy and also in private practice for that matter, this actually really binds everything, so you can start to account for your time, account for cost, account for your business models. Even though I'm a clinical academic, I have worked in practice for many years. I've never run a practice. I'm not claiming I'm a business person, but I also see the value of the business side. The beauty of this is, number one is patient care. Obviously, that goes without saying. Number two is what you've just said, professional sort of validation and doing the right thing and just itemizing things out. Okay. And then thirdly, you've got this whole idea of essentially running the business and having a right business model, using correct members of the oral healthcare team, and getting people to value, all the different stakeholders, patients, the profession, everybody, to value what we're trying to do. And you said it at the beginning, yes, you could argue this is semantics. You could argue this is sort of playing with words. But what I found, I just mentioned about the dental team a few minutes ago, right? I've asked politicians who are the members of a dental team, right? And these are people who are sort of in charge of what we do, okay? And they say the dentist, they say dental nurse, and that's it. All right? People forget about the reception staff, about the clinical dental technician, about dental hygienists, dental therapists, extended duties dental nurses, oral health practitioners, and so on and so forth. And they're equally, if not more valuable than the dentist, actually, in all of this, for the majority of the patients that we treat. So having this MIOC framework, I repeat, is not complicated. It's exactly what you were taught at dental school. I've just given it labels that we can then hang onto those, all the principles that you've just said, from from diagnosis and treatment through to communications and through to empowering our patients. And something else this fits into, and we mustn't forget, the whole sustainability story in terms of environmental sustainability, socioeconomic sustainability. The drill, fill, bill model is not sustainable in any shape, way or form. So this all fits into all of this. I'm privileged to chair sessions at COP30, at COP31. We're developing for November, which is the Global Oral Health Climate Action Conference. All of this is playing a part now, okay? WHO are talking about it. So it's building momentum. And there's something else which is really key, especially generationally with the patients we're going to be treating as I get older, as you get older. And this is something called salutogenesis, which you may or may not have heard of. So this concept has been around for many years. Essentially, we're looking at improving health, and what we're talking about today, oral health, oral and dental health, rather than looking at negatives and looking at problems and to overcome. The actual argument is to look at positive solutions and positive promotion. So, when a patient comes to your clinic and they sit down, we ask them, what's the matter with you? All right? How can we help you? What's the matter? So that's already a negative connotation. And actually, salutogenesis, the best way of summarizing it is to change that question to what matters to you. It's a subtle point, really subtle, and it's a psychological point, but it shifts the dial again, and it goes back to shared decision making. You take the patient, the caregiver with you along this journey, and you do that. It means you are actually doing behavior change without even realizing it, because you're empowering the patient, you're facilitating the patient to take value of their oral health, because most people don't realize how important their oral health is to systemic general health. We do as a profession, but very few other people do. By doing this, your communications get better. The patient can discuss the care plans with you. You're still in charge of them and you're still going to make your clinical decisions, of course. But now, because you're doing this in such a nice way with care planning, not treatment planning, and the difference is, care planning, you have justifications written down. So why are you doing that filling? Why are you doing the endo? Why are you doing active surveillance and not intervening?
And all those whys link back to what matters to them.
Correct. Bingo. Bingo. And therefore, this all fits. It sounds very complicated when I'm talking about it, but actually you're doing it already. And as you said earlier, we're just structuring it, making it easier. And we're talking to electronic patient record systems to make it easier to record. So this is the shift, the direction we're going.
I love this so much. It reminds you, I mean, I'm so glad you mentioned communication, because for me, when you start doing that, the biggest thing you'll see is how you'll be able to communicate more effectively with patients, because then you talk in their own language, because they've just told you what's important to them. And then you can actually make better joint decisions and better recommendations, because we're allowed to recommend a plan to patient based on what they say. And so, when they say, this is what matters to me, well, because this matters to you, actually, I'm not going to recommend denture because that could have other issues because these things matter to you. And then it helps you get clearer on and more confident in your recommendations. The other communication thing I just want to touch on is a hat tip to Dr. James Goulnick, so involved in kicking sugar out. He taught me years ago, probably like 15 years ago, that when you're doing an oral cancer examination, you tell the patient, I'm just going to check for oral cancer. Now, it's something that we already do, but when you tell the patient you're doing it, they're like, oh, no one's ever done that before. But actually, the last 50 dentists have all done it, but no one's ever said it. So again, it all goes part of communication. And this framework that you're suggesting, there's a lot to take away in terms of how we write to our patients, how we speak to our patients. And I think it's just beyond the management of the disease. It's actually a big wrapper on communication as well, and the kind of oral health importance we sort of convey to the patient.
Again, you've taken the words out of my mouth. That's precisely the point. And I think for me, I'm a huge advocate of using the oral healthcare team. That's why people are trained. People have scope of practice. And, with business models that we have in practice, they can be tweaked and they can be improved to incorporate this, to make the whole team sing from the same hymn sheet, so to speak.
Let's talk about something clinical. Let's talk about caries interdentine. I was taught that radiographically, there's obviously radiograph is not your diagnosis. It's just one source of data that helps to inform your diagnosis. There's your clinical diagnosis, there's your imaging diagnosis. You have to match it up and look at the patient as a whole. But if you think about radiographic diagnosis and you see radiolucency interdentine, I was taught in my generation that back in the day we used to see that, we used to drill in, but when I was taught, it's like no, we don't need to do that. We now need to check if the surface has cavitated, because surface is cavitated, then that is a reason to intervene. Has anything changed there? Have we managed to become even more conservative that actually it has to be a lot more cavitated, or is that still the same, or any guidance you can give to that, what I was taught?
Yeah, so essentially what you were taught was correct. We are fine-tuning a little bit, but that's all it is. Ultimately, when you do your examination, ideally with loupes or some form of magnification would be the ideal. I appreciate can't always happen, but I think in this day and age, there's less and less excuse.
I don't trust anyone without loupes, Prof.
Absolutely.
I advocate that all the time on here.
Absolutely. So good loupes, good lighting, etc., etc. So the argument has always been, we look at the progress of the lesion, and you can look at the progress of the lesion, if you like, histologically and clinically, and you can look at the progress through the lesion radiographically, which is still obviously histological, but using the radiograph, okay? There are, of course, other detection devices, and they can work very, very effectively, but I think most of the evidence has shown over the years that the clinical examination coupled with the radiographic is still our sort of gold standard. But I do caveat that we do have technologies now that are getting better, optical technologies, fluorescence technologies. So the point is, you're looking at lesions and they will literally progress from a healthy tooth to the earliest white spot enamel lesion with porosity that will spread through the enamel, hit the EDJ, then start to spread into dentine. So we're looking at that, but we're also looking at what's happening on the tooth surface, the roughening of the white spot lesion, okay, as edemens really takes effect, and ultimately the breakdown of the tissues and then cavitation. So the key point really, if you're going to pick up a drill, cut to the chase, if you want to pick up a drill and do something, the factors you've got to think about are cavitation. Can you see a hole? That's point one. And of course, you can have microcavitation as well, which is harder to see. However, depending on the radiographic depth, you can still even seal some of those if they're in the outer third of dentine. But if there's obvious cavitation, where you can see some dentine at the bottom, of the hole, as it were, then think about what's going to happen. You've got a hole. That hole is going to get filled with plaque, biofilm, and the patient can't get a toothbrush or floss or anything into that hole to clean it out. So as we all know, the biofilm then changes. It becomes dysbiotic. That's the ecological change in the microbiome. So it becomes cariogenic. And the way I describe it to my students is it's as though you've turned the engine on and the engine is revving away, okay? So the process is happening. And because that biofilm is growing and it stagnates more, now you're sort of putting the car into first gear and the car's moving, okay? So the process is active, i.e. the caries process is happening. So you've got cavitation that leads to cleansability, i.e. can the patient clean it? And that then leads to activity of the lesion. So those are your three factors. Now that's in an occlusal or in a proximal. Now, if you have a situation where you've got a buccal cervical lesion, right? So think about the location now. You get a buccal cervical lesion. The reason why this is so important, because we're talking about should we go in with a drill and everything else, you might still have cavitation. Well, you will still potentially have cavitation. So does that mean you pick up a drill and drill a hole? Absolutely not. Because on a buccal cervical, on a smooth surface like that, you can potentially make that lesion cleansable without necessarily having to do an extensive amount of drilling. Mm-hmm. So you can saucerize the cavity, make it easy for the toothbrush to get in, and then educate the patient on how to clean it with a toothbrush and a bit of toothpaste. Okay? And guess what? If the patient disrupts that biofilm, literally within 2 or 3 weeks, the lesion arrests because the engine of the caries process is the biofilm. So for us, operative dentistry isn't about the lesion, it's actually about the biofilm if we're actually managing disease. Now, of course, if you've got big holes in teeth, there are going to be structural, functional, aesthetic issues. Of course there are. And of course, that's another reason for filling teeth, obviously. But what people forget, the main reason is by putting your restoration back in the tooth, you're making the contour, the surface of that tooth cleansable again for the patient. And then the priority is going back to primary prevention, educating the patient about using a toothbrush properly, using floss or whichever aids, and using a toothpaste, and so on and so forth. So it always falls back to what the patient does at home.
Hello, YouTube Protrusive. I know you're watching on YouTube, and I hope you're enjoying this episode so far. But I wanted to highlight, in case you don't know yet, we have an amazing viewing experience on protrusive.app, our website, our network, our platform. So I just want to spend a minute to show you what this looks like. On the left side, you see the navigation, and when you join the app, you get a 1-minute video tour of the entire network. Now, in terms of where the magic happens, that's in the Protrusive community, because you might come for the content, but you'll stay for the community of the nicest and geekiest dentists in the world. We have all these polls, we have a chat group, there's always active chats and dentists helping dentists. And really what I want to do is create a really supportive environment that's not like the environment we have on Facebook, and is built on the values of niceness and geekiness. If you are nice and geeky, you belong here. Now, to make this a safe space, we have a manual process of approval. We actually verify that you are a dental professional before you get in here. So we have hundreds of applicants a day. So if it's been about 2 days and you haven't heard anything, either something's in your junk or you need to reach out. If you're still waiting to join your tribe, email marie@protrusive.co.uk. That's MARI@protrusive.co.uk, and she'll investigate what's happened. Now, all the videos you have on YouTube are also on here, but you actually have some extra ones for free that you don't have on YouTube. So you get some bonus content that's not on YouTube. And actually for the future, I'm not taking things out of YouTube, but some things are not appropriate for the wider public, and I want to sort of safeguard that information, which is like dentist talk, if you like. So that's why a lot of the content is only here and not on YouTube. So you're kind of missing out if you're not on here. That's why I'd love for you to join there. And if you join one of our paid plans, then what you get is access to the CE quiz, like this one, and you can get CPD or CE certificates, and also you get our premium notes. So these are a great aid memoir or revision for an episode to really cement your learning. And whilst we have ads and YouTube places ads on YouTube, we don't have that on our
our network. So for the paid plan, you get to see all of the premium notes without any of the ads. And of course, you get to support Team Protrusive and help us to continue what we're doing. I'm just going to gloss over the Protrusive Vault, which has all our infographics and downloadables. These are all our masterclasses at this moment in time, and we're always planning to add more. And if you look at them, there's about 1, 2, 3, it's about 7 of them. But actually, if you look at the replay section, some of the live masterclasses that I've done and some of the training that people pay for on other websites is all on there, included as part of the masterclass subscription. And if you're a student, don't fear, we have a special section for you with all the student notes, which anyone can access. So for example, here is one on exodontia. So it's all there waiting for you on Protrusive Guidance. Please head over to the website, which is protrusive.app. Make an account on your browser. This could be Safari, Chrome, however you want to do it. And once you've made your login, then you can download the iOS or Android app and then log in through there. So the reason to make the subscription primarily on the website first is that you get access to a free trial, which you don't get if you do make an account on Android, iOS. If you make it on the website, you get access to the free trial, and you get our best price if you sign up through protrusive.app. So our best deals and free trials are only on protrusive.app. Of course, we always put the link below in the description, and thank you so much for enjoying our videos on YouTube. But it's now finally time to level up your experience. Back to the episode. You raised 2 good points there, Warren, thank you for answering that one so succinctly. But you mentioned in there a couple of nuances, and I'd love to explore them. One is technology, because yes, using magnification lighting and radiographs is kind of like the gold standard. But if there was one technology that if someone came to you and said, hey, I have a busy practice, we have 7 surgeries, we'd like to do more, help our patients be higher standard of caries diagnosis, which is the one tool you might recommend? For example, the iTero has that, I don't know, NICR or something. I don't even know what the terms are, to be honest with you, but iTero, I use it sometimes, but I don't know, being very honest about how effective it is, or is it gimmicky? And there are other fluorescence tools. What is the one thing that you think could level up our caries diagnosis in addition to good clinical observation and radiographs?
Honest answer, I don't think there is one at the moment. I think part of the problem is we live in a world now where we want lots and lots of evidence and proof that something is better than something else before we use it and use it as a norm. Okay, so there are lots and lots of different technologies. You're talking about near infrared imaging from your iTeros. Okay, you've got fluorescence technologies and optical technologies that are out there. Diagnodent has been out there for a long time, for example, many years, and there's lots of iterations and variances on these sorts of technologies. So they exist. The physics is very clever. The physics is not foolproof for any of these technologies. There is no perfect technology that will give you 100% sensitivity and 100% specificity when you're looking at a disease. Not one, okay? So you always have to use your noggin to interpret what the device is telling you, and that interpretation is key. But what I will say to you is that if you're doing your clinical examination carefully with magnification and good lighting and everything else, you're taking good quality radiographs, and now with AI that potentially can help us as it sort of machine learns the subtle changes in early lesions and things like this. What you can then do is pick one of the technologies. There is always going to be evidence to show the technology works to a degree. The point being is a lot of that is done in the laboratory, or those experiments are done in the laboratory, or they're done in very controlled trials in patients, which they have to be. That's not a criticism. That's life. Difficulty with interpreting that data into your practice or into my practice is that we don't have a controlled environment. We have a patient, we have all the different variables. And so you have to adapt and understand the technology. So my actual answer, sorry, it's a very long-winded answer, but my answer to you is this. It's not about what specific technology. I would say to you, if you want to use technology and use it, I'm not saying don't. What I'm saying to you is really learn and understand how the technology works, really, in depth. Learn some physics and understand how the optics or whatever it is interacting with histology to give you the data that it's giving, whether it's an image, whether it's a number, whatever it might be. And then once you know how it's working, you will start to work out its limitations. And by doing that, you can then interpret the data sensibly for that tooth surface in that mouth, in that patient, in that clinic, on that day, with that weather and everything else. You interpret it better. And in your notes, you write down what you find and what your interpretation is. And that, again, you discuss with the patient, and it goes back to what we were saying about MIOC and pulling it all together. So it's not guesswork. but I don't want to say use product X or technology Y, because people sometimes hang on those words and go and do it, but they don't then sort of really think it through. And that's really what I want our colleagues to do, is think about what we're doing. We're all very bright people, you know, and we should really, whatever we use, we should really be working out what's good about it, what's bad about it, how it works.
So my takeaway from that is I've got an iTero, and you know, iTero's got a huge market share, right?
Yeah.
And so a lot of my colleagues have an iTero. But, and it's okay to use, but what I need to do is go away and really understand exactly the image that I get from the near field detection is, okay, what is that? What are the disadvantages? And so we owe it to our patients to do that. So that's why I haven't been using it, because I haven't really understood it. And I just use my radiograph and clinical diagnosis. But if you're going to use that, just make sure you know the ins and outs. I think that's a good way to do it, because then it opens up whichever technology you want to use. Just make sure it helps to in the correct way.
Absolutely. So you're going to do a little bit of reading, obviously, about it and everything else, because there will be publications, there will be writing on that that's been done properly. But what people also forget, you've got the kit. So you start to calibrate yourself. So you take patients where, if you're going to use it for caries diagnosis or white spot lesion diagnosis, find some patients where you can clearly see the white spot. Then zap it with your scanner and start to build up. You know, how we talk about AI and how you have to feed it information, right? Well, our brain's AI. You have to feed it information. You only become better at detecting disease when you keep looking and looking and looking and looking. All right. And you're looking at health, you're looking at gross disease, you're looking at mild, moderate, you know, initial disease, and your brain is AI. It's taking that information and it's layering it. So each time you see it, but the beauty of your brain is it's also taking into account all the patient variables. Now, AI will start to do that. Of course it will. Of course it will. But it needs to be fed. The human brain, you're doing that every day clinically, and don't underestimate that. Don't be frightened to take things that are a bit obvious to begin with. You say, oh, there's no point using the scanner on this. Well, actually there is, because your brain is assimilating that information.
This is the same as when an experienced dentist and a baby dentist look at the same radiograph, and it can be interpreted completely differently.
Absolutely.
Because the experienced dentist has you know, let's say they've operated on that exact situation thousands of times, and they know that what we're seeing is going to be a lot more extensive, for example. And then the colleague may not, the younger colleague may not appreciate it. So I think it's the same way. It's giving. So I think that's a great way to use that technology if you're new to it. Now, we've had so many contributions from the community, wanted to specifically ask you questions. And I guess the two-part flow of this episode is that we can make the initial part that we're talking about now more about early caries, and then we'll talk about deep caries management perhaps in part 2. But the second part of one interesting thing you said was, when you have that earlier caries lesion, maybe just about cavitated or micro roughness or micro cavitation, what are the roles of the resin infiltration, interproximal resin infiltration? Is that something that's got good enough evidence so far? Is that something that you use or have been advocating in your programs? How is that doing? Because as a wet finger dentist looking at it, it looks very fiddly. I use that product by DMG on anteriors for white patches. I love it. But the big barrier to me using it interproximally, it looks incredibly fiddly. And I'd love to know from you what the latest research says on, is the juice worth the squeeze?
Yeah. So again, really important. And before I directly answer that, let me take one step back slightly. Yeah. And it goes back to what I was hinting at the beginning about MIOC and about the changing the dial and turning the dial. Many of us, many people listening to this podcast, and people of my age and older, and yourself for that matter, a lot of dentistry we use this phrase, watch and wait, for early lesions. Hate that phrase. Absolutely hate that phrase. This idea that, you know, you've got early lesions. Yeah, you tell the patient to use a toothbrush and toothpaste and crack on, everything will be fine. Guess what? It's not. And then we get bigger holes in teeth, and then we start drilling and filling and billing. So it is a completely wrong healthcare system. And what we should be doing is early detection and then management. Not watch and wait, is detect and manage. So this is where all the technologies come in. 30, 40 years ago, we didn't have the technologies. That's fair enough, okay? So we could only relatively see things, relatively speaking, late stage. Now we can see things earlier and earlier and earlier. And the danger now is everybody's saying, oh, but if we see something early, we'll go and treat it, and that's overtreatment, and should we do it? Okay, right. So the analogy I've always used, because we're trying to put the math back in the body and link oral health to general health, you know, if I go to the doctor and they start to see my blood pressure's going up, what do? They don't just say, sort your diet out and take some more exercise. Obviously, they say that, but is that all? And send you away? No. They start giving you anti-blood pressure tablets, don't they? So they start treating you. If you're pre-diabetic, and you go in, or you've got early diabetes, what do? Obviously, they will talk about primary prevention and get your diet and exercise and everything else. But actually, they will start looking at medications to prevent things getting worse quickly, right? But in dentistry, what do? We just let the disease sit
Watch
there.
and wait.
Watch and wait, right? So that philosophy, in my humble opinion, is broken.
But you know what, I think to be fair to the profession, I know you've thought about this as well, is that the whole reason we do that is to try and operate in a more minimally invasive way, because we know we can arrest, and so the intention is pure, isn't it?
100%, but no, I take that, and I appreciate. I may have come out sounding a little bit anti-professional. I didn't mean it that way.
No, of course
I meant it the way you've just said. That absolutely right. The problem is we sort of put it back on the patient. Sadly, most patients don't brush their teeth well enough. They don't moderate their diet well enough, and then lesions get worse. And then what do we end up doing? We end up drilling, filling, and billing. And then we use the term minimally invasive, but we're not actually being minimally invasive, because what we should be doing is managing non-operatively, i.e. what the patient does at home. We need to be managing micro-invasively, as I hinted a few minutes ago, and then minimally invasive for the holes in teeth that are already there. But if we're catching something early in modern medicine, to note something early and then not do anything about it, that's not acceptable anymore. Now, the question then is, what do we do? Now, if people are then saying, oh, we've got a white spot lesion, or we can see it, oh, well, I'm going to drill a great big cavity in there and put a composite in, then clearly that's crazy. And the beauty now, and I keep saying now, I've been doing dentistry 35, 40 years, and it's only in the last 10, 15 years the materials have really blossomed, the technologies have really blossomed. And so we now have a whole bunch of materials that we can use that are essentially topical, or they're micro-invasive, to allow us to start treating. Because treatment to a lot of clinicians and to patients is, they're going to pick up a drill and do something. That's what the word treatment often equates to in dentistry. Not always, I know, but often. Or at least it's a perception. And what I'm arguing now is that the word treatment doesn't have to be operative, right? It can be this micro-invasive. So the things we have there are your resin-based sealants, Fisher sealants for preventive, therapeutic, and sealant restorations. And then we do have resin technologies, and I'm not sure we can mention company names.
We can.
Yeah, and there is only one anyway that really makes it, which is DMG,
resin infiltration,
exactly,
proximal.
Exactly, and that's been around for a long time. There's been a lot of research done on it, both in the laboratory and clinically. And again, no one is arguing that this is what you must use in every single case of something. All right, it is in our armamentarium, and it can work very effectively. And the concept, for those who aren't totally aware, is essentially you have an early sort of white spot lesion on the tooth. You put a very, very strong sort of hydrochloric acid basically onto the tooth. It sort of burns through that mineralized layer at the surface of the carious lesion, and the enamel basically makes the pores a bit bigger to allow the resin to infiltrate and penetrate in. And then you cook it with a light, and it can basically seal up those holes. That's the principle. There is plenty of evidence to show in the right patients, right situations, it can work very, very effectively. So it's a big thumbs up. And you're commenting it's fiddly. Everything in dentistry is fiddly until you become practiced at it, isn't it?
Especially if it's a proximal, yeah, absolutely. No.
But they have protocols there. They have the kit to allow you to do it. And the fact of the matter is, the first time you put rubber dam on, it was fiddly.
Yeah, oh yeah.
The first time you handle a bonding agent, it was fiddly, and so on and so forth. The more you do things, the less fiddly it becomes. So that's one area. So we've got the sealants, we've got resin infiltration, and I hinted about peptide technologies there as well.
Can I just because I'm so pleased you've talked about and educated me about these resin infiltration system and how you've given the thumbs up, and so I will, because I've been umming and ahhing about it, and it's great to have this vote of confidence. It just made so much sense to me about when you compared that analogy and how in medicine we manage things, right? We are to be micro-invasive and appropriately manage it while we can, and it's possible. It makes so much sense. But what I'd like to here is if you have some guidelines on, well, if you get to this point, actually it's too late for resin filtration. You got to get a diamond burr out and actually cut out a hole. And actually at this point it's too early. Why have you considered fluoride varnish or SDF or peptides, as you'll come to? So any guidelines of what is the sweet spot of diagnosis, whether clinically or radiographically, that's amenable to this particular technology?
The sweet spot, again, it's always difficult in this part of cariology because we're talking about such subtle changes in the mouth. So we can talk about, again, I'm sure your listeners are aware about E1, E2, D1, D2, D3. So the radiographic levels of lesions, outer enamel, inner enamel, and then dentine split into thirds, D1, D2, D3. Okay, that's fine. And that's great, assuming you've got really high quality radiographs taken with the perfect angulation and everything else. Then you can sometimes see that. That's amazing. But let's be honest, in real life practice, can you see the difference between an E1 and E2 on a radiograph all the time? Of course you can't. Okay. No one's fault. No one's to blame. That's just life. And one of the things I really want to get across today is that, I am a clinical academic. I've done lots of research. I still am. I've got PhD students looking at all these things we're talking about. And we can sit, and one part of my brain is saying, yeah, this detail is brilliant and we can do it. We can give a sweet spot and we can say an E1 lesion ideally should be topical at home with fluoride varnishes and toothpastes and so on and so forth. An E2 lesion, now you're starting to think potentially microinvasive. Right? You're still doing the other things, but you now maybe for some lesions in that same patient, they're not quite getting their brush on it properly or whatever, they're struggling. Then you might think of a sealant, resin infiltration or a peptide technology, for example.
Or maybe so, like you see the patient and then at the next bitewing interval, you see that it's gone from E1 to E2, for example. Obviously, the ideal technologies and whatnot. And so that is a potential situation for resin infiltration.
Absolutely.
There, for
exactly. Or whatever microinvasive technology. But again, this all boils back down to whether you have the actual skills to get your detection device to show these subtle changes. And again, this is where potentially your AI can come in and help in the future in terms of helping you analyze some of the, radiographs, for example, or other technologies. And I use the word help. Not do it for you, but help you. And that's a very, very key point. It's adjunctive. AI, I'm a fan in some ways. I'm a skeptic in others. And as long as AI is adjunctive and learns with us, then brilliant. It'll be absolutely brilliant. If it takes over and stops us from thinking, then we've got a problem because it will never beat the human brain because of the variables that we have to deal with. Okay. So in terms of answering your question, the sweet spot will be that E1 to E2. If you like, but I repeat, that's great saying it out loud in a podcast or if you've got the perfect radiograph lined up. But if everybody did an audit of their radiographs, could you honestly tell me you could see progression from E1 to E2 on a bitewing where you've not necessarily standardized the angulation and everything else? It's always tricky.
What I want to establish is D1 but not cavitated. D1
Correct.
But not cavitated. Is that okay for resin infiltration?
Right. Now, then you see resin infiltration will only penetrate into microns into the enamel, right? Okay. It's a certain number of microns, maybe 50, 100 microns, okay? What you may want to be doing if you've got a lesion now radiographically, a slight shadow into dentine at EDJ, slightly in there, but no obvious cavitation. So you've got that maybe a slight shadowing, through the occlusal surface, around fissures, or classically when the tooth is wet, you've got saliva on it or water on it, it looks normal, but you take your 3-in-1 and you blow the surface and it becomes frosty. Those lesions, you are probably looking at using a fissure sealant and doing a therapeutic fissure sealant as opposed to resin infiltration.
But interproximally?
Interproximally is harder, much, much harder, absolutely. So in that situation, those are occlusal fissures. You're absolutely right. Proximally, it becomes more difficult. And then resin infiltration might be an option there to try to sort of seal off that surface. But always remember, these things are not in isolation. They're always going hand in hand with primary prevention. So your oral hygiene, your fluoride toothpastes, and all those things. So please remember, even though we're talking about things a little bit separately for obvious reasons, the actual care given isn't separated.
There we have it, guys. Now we know that proximal resin infiltration isn't just a fad. It's not just a fiddly gimmick. We should be offering this to our patients. What's holding us back? What's been holding me back all this time? I don't have the training. Even though I can do the most intricate class 2, I've just never used the kit before. I'm one of those guys that I just want to be shown how to do it once or twice before I do it myself. And that's kind of held me back. But also I didn't have confidence in the product because I didn't do my own research. That's why I asked Prof, is proximal resin infiltration any good and should we be offering it? And he just gave a huge thumbs up. So then that sparked my interest in learning about it. So then I got in contact with DMG UK and asked them if they have any courses, and they said no, they don't. And I begged them, like, please, can you put something on for us? And can you do something that our international audience can also benefit from? And I'm amazed that they turned this around, but they've secured a webinar. There's actually 3 things we've secured. And so the number 1 is a discount on your first order of Icon Proximal. It only works for 1 order per dental care professional, so don't try and be cheeky. So it's a 20% discount on your first order of Icon Proximal. Number 2 is the webinar. The webinar is with my good friend Kat Edney. The webinar is called the Iconic Method. It's an introduction to Icon resin infiltration and modern enamel management. You'll learn all about the principles of both vestibular and proximal resin infiltration. The webinar is on the 24th of June. But if you're watching this episode in the future, still go to this link and you'll be sent a replay to this webinar. And then the third thing, for those of you who like me, who like to get a little bit hands-on, it's a hands-on course on Saturday, 4th of July. It will be held at Align Technology in Birmingham, UK. And it's a full-day hands-on course, all things Icon resin infiltration, whitening, and NIRI caries detection. It's just £349, which is incredible for a hands-on full-day course. Many of you, and those of us international, will be just fine with the webinar on the 24th of June. But if you live local, if you want to experience the magic of hands-on, then you're probably better off going on the hands-on course. To find out the details on all of these things, all you have to do is head over to protrusive.co.uk/DMG. That's protrusive.co.uk/DMG. Enter your details and you'll be sent all 3 things by DMG. The discount, should you want it, which will be also be valid after the webinar and the course in case you want to wait until the education before you purchase. Some of you just ready to go and crack on. You'll get the webinar registration details and the in-person course details. So all 3 things are at protrusive.co.uk/DMG. Personally, I'm looking forward to learning myself so I can help my patients with a more proactive approach. I'll remind you again at the outro, but let's rejoin this episode with Prof. Banerjee.
Outline.
Oh, no, you've definitely been very clear and all-encompassing with that. And I just wanted to say, like, we've got, again, so many questions from the community, and then so one of them was about AI. So what we'll do is the next 2 questions will be, now that you touched on AI, the question from Dr. Yazan Duadari, long-term community member, he says, how trustworthy are AI X-ray caries diagnosis? He says, I feel it overanalyzes quite a bit. And so that's his question. So you've already said that we can use it as data, but we can't let it guide you. Yeah, take over. You have to still use your judgment. But is it thumbs up or thumbs down from based on what you've seen for AI to help you?
The difficulty, AI is just moving on at such a speed. It's incredible. Okay. And AI is only as good as the information it learns from. So the better the information that's fed to an AI system, the better it will become. Okay. That's simple rule number 1. Now there are clearly plenty of AI software, if you like, out there, AI apps that will help sort of read radiolucencies and assess them. And at the moment, if you're using them, that's great. But as I've always said, and I've said earlier, that you have to use the serotonin and the acetylcholine that's in here as well in your brain. Because ultimately AI isn't going to get sued. You will if you get it wrong. So you've got to make the judgment call. So what you have to do when you're doing, especially early caries detection, because that's tricky, that's difficult. Cut to the chase here, that's difficult. And early caries detection, again, what I try to teach my students and postgrads is you've got to triangulate. And you asked me earlier, is there one particular detection device technology that could really be a game changer? Ultimately, maybe there will be, who knows? But at the moment, we have multiple bits of kit. And what you do is you triangulate. So you will do your clinical examination carefully. You will take good quality rads, because that's still part of it. You will use your other fluorescence detection devices or whatever else. You can then use AI on top of that if you want to. Now, you're not going to do that for every single carious lesion in every tooth in every patient. Of course you're not. We're talking about those early ones, the ones that you're thinking, what do I do? Is it really a lesion? I'm not sure. When you're in doubt, that's when you triangulate. And that will then, all you can then do is give your best opinion, learned opinion, based on your experience, knowledge, and based on the information you've got. And tell you what, you can speak to any indemnity provider. No one has ever been sued for making an error if they've done all of that and the judgment call ultimately is proven to be the wrong judgment call. No one gets sued for that, because what can you do? You can only go on the best information you've got in front of you, right? If you blindly just take an AI piece of software and then you let it scan your radiographs, and the radiographs are not very good quality and everything else, and it starts telling you there are lesions where there aren't lesions, or they're bigger than they should be and all this, well, you're feeding it. It's spewing out information that it's being fed. So ultimately, the human, the clinician, takes responsibility.
So what I've done so far, Prof, is if my principal decided to invest in AI radiographs, I'll be all for it. Just data. It's nice to have data and to
100%.
triangulate with. I love that term triangulate actually,
Yeah.
but I'm not going out to buy it outright myself just yet because I feel as though yes, it's a good aid, but it shouldn't replace your judgment. And that comes first. But I think if you have it, I think I love data personally. In occlusion stuff, I'm always getting data. But one thing you just remind me of with triangulate is a really good clinical lesson I learned. I was maybe 3 or 4 years qualified. My principal at the time, who I'm not going to name, but lovely chap. You know him. Actually, I'll tell you later. Really lovely chap. And he fed me so many patients. And one patient he saw, he took a CBCT and he found a radiolucency under a second premolar. And then he referred to me for an endo. So I see this chap, a completely unrestored tooth, right? And I do my usual checks and I do my sensibility testing, positive to endofrost, like a healthy positive. And so I send the patient home. I'm so sorry. I think everything's fine. I don't know what that is. We'll get that looked into. But this tooth does not need a root canal. Okay, you can go home. And this was just a great example in a similar scenario. If you just use one data point only, and you don't look at the others. And so on that day, looks like I triangulated and I think something doesn't quite match up. And so if you rely on the AI without looking in the mouth, for example, properly, like actually properly drying, wet, everything, then you will far more often.
Absolutely. And you again think back to what you were taught. You don't treat a radiograph. You don't treat an investigation. So because you see something on a RAD or a CBCT or whichever investigation, you don't automatically just treat it. What you do, that's a red flag. It's a warning bell. You'd go back, you reinvestigate the tooth. You might check other aspects. Just look again and look a bit harder, just to double, triple check. I have this issue now. There's so many cases of cracked tooth syndrome now. It's probably the lifestyle everybody has of being stressed out all the time. And you and I know, and I'm sure all our listeners know, that something like cracked tooth syndrome can be an absolute nightmare to diagnose and then to manage
and to communicate.
Because the patient's in exquisite pain, but there's barely anything wrong with the tooth apart from the most minuscule hairline crack, which you and I know deep down cannot be causing that level of discomfort, but therefore there has to be something else. But what do we do? And all right, we're going off tangent here, but if you bring it back to caries, it's the same principle. But there are so many factors involved in terms of management. And I know we live in a world where we want guidelines, we want protocols, we want step-by-step guidance. But as I'm getting older and I talk to my students and postgrads and other people, I actually sort of say, do you know what? There's too many steps and protocols. People rely on them and you switch your brain off. And don't forget, doing dentistry is difficult. That's why it takes 5 years plus another 5 years of training afterwards to become even, I would say, competent. There's a reason for that, because it's damn difficult. Now, guess what? You are allowed to make mistakes in the sense that, a decision may not be, with a crystal ball, may not be the right decision. You can find out 6 months later or a year later. I repeat earlier, no one gets sued for that as long as you have made that decision justifiably. And I use that word a lot. You have to justify, and that goes back to your care planning. One has to justify why you are doing stuff. And the line, again, I always use, if you justify what you're choosing to do to yourself, to the patient in the chair, then actually you won't ever have to justify it to the person wearing a wig and a gavel.
Always to write it in your notes is a powerful thing, actually, to all the justifications.
Absolutely.
It's not, and even to patients, I'm a big believer, inspired by my good friends at Pankey, is talk your think. Talk your think. Just talk out loud. What is going on? What's your reasoning behind something? Is very, very powerful thing, even to patients. Now, you've answered comprehensively on the AI, and I think we're both in agreement. But peptides I have very little knowledge on, and that's in the sort of micro-invasiveness. And so Dr. Jerry Brown says, what is the efficacy of the new peptide by, specifically he said V. Vardis. I don't know. They have something called Curodont. Is that the only one, or are there others out there? And I have nothing about this, so please educate me.
So again, it's another technology. It's not.
There we have it, guys. Part 1 ended on a cliffhanger. Thank you so much for listening to it all the way at the end. If you've already been using the terms active surveillance and using the frameworks that Prof touched on, then pat yourselves on the back. You are a true modern dentist that is minimally invasive and proactive. If not, now's a great time to change your protocols. If all you're offering is diet advice, fluoride varnish, and then a restoration, then there's so much more we could be doing, and that includes peptides. Everything about peptides, how they work, if they're effective, we're going to touch on that on part 2. For example, SDF, silver diamine fluoride. When should we use that instead of fluoride varnish? Are they as effective as each other? Is hydroxyapatite in toothpaste that a good thing or a bad thing relative to fluoride? And everything from stepwise excavation, is that a thing anymore, to managing caries in the extreme xerostomia patient? That all awaits you in next week's episode. For now, don't forget to answer the quiz, get 80%, and our CPD Queen Marie will send you a certificate. If you're not already part of our membership, you are missing out. You already enjoy our episodes, you listen all the way to the end. That's a real achievement. So you deserve a place in our community. Head over to protrusive.app, make an account, and you'll be racking up those CPD hours like in no time at all. We are a PACE approved provider of CE, internationally recognized. Inside our membership, we also download the transcripts, the premium notes, all the promised papers. They all go inside the premium version of the episode and an area called Protrusive Vault. So do check out all the resources for this episode. And don't forget that special offer from DMG. You can get a discount. It's limited to one order per dental professional, and it's a discount on their Icon Proximal product. The website to order is protrusive.co.uk/DMG. That's protrusive.co.uk/DMG. I'll also put in the show notes all the information about all the upcoming education for Proximal, because it's good enough having the kit, but how do you actually use it? What are the little hacks for this fiddly area, this fiddly procedure? Any education, including upcoming courses, I will put in the show notes. Don't forget to scroll down and check it out. The best place where you get it all cleanly and nicely is, of course, the Protrusive Guidance app. So head over again to protrusive.app, where we will look after you. Thank you so much, and I'll catch you same time, same place next week for part 2. Goodbye for now.